The broadcast is now starting. All attendees are in listen-only mode.
Hi everyone, this is Hart Matthews with Whole Health Now, and we are here for a session on injuries tonight with Dr. Joe Kellerstein and Dr. Marianne Ivans. We are going to take a look at wounds and fractures and other injuries at home. You guys want to take it away?
Okay. Thanks, Hart. Hi, everyone.
Good evening.
We're going to start tonight because the purpose of these is to get you not only familiar with looking at Whole Health Now, Hi, Kim. I hope you're there. With Homeopathic HouseCall, but we want to show you one of the features of the system that is going to help you, and it's going to help us assess how we're doing. And so to do that, I'm going to go into that program now, and what I'm going to talk about is this right side where it says recent house calls. And if you go into one of those on the right hand side, you're going to come to an assessment tool. And this assessment tool helps you, well, basically helps us because we know if this is working for you. And so if you would just take a few minutes, probably not even that long, to fill out this form. Let's see, Randy Given. I'm just going to fill it out like I'm playing how many doses, 2 to 3. It's given, rate the results. I would think that this rating system is 4 is the best. Let's just say I'm good at prescribing.
And you are.
Actually, I had an Atlanta case this week. One of my students in South America called about it, and she just told me today the little girl was doing really well. So I'm considering that. And actually, I used the program after I prescribed, and it came up with the same remedy, so I'm feeling very confident.
Isn't it nice to know that you confirm you?
It is nice to know I confirm me. How often do we get that chance to do stuff?
It's quite rare, isn't it?
It is.
And normally
okay,
we're very self-critical.
We are very self-critical. So, and then you answer those few questions, and you do submit. And that submit sends this back to us, and we can see if people are having a problem with this tool, and we can try to figure out why. And of course, as we talked about last time that Joe and I were together, being able to observe symptoms is one of the biggest pluses you're going to have in using the system correctly, because the better you can observe symptoms, the better are going to be your answers to the questions. So is there any question about this before we start in on the other part of the program?
No questions yet. I would add that, sorry, my brain catching up with me.
That's all right.
I would add that the other purpose of being able to report our results is we can go in and actually document the effectiveness of homeopathy for
Yes.
the world at large, and not to worry people who might be watching this, watching us fill in report results that may or may not have actually happened. We can separate ours out. Since we're administrators of the website. But when you report yours, make sure that it's a good report, because we really do want to know whether it's working for people or not.
And you know, it's so important. Remember, you know, one of the great physicists, philosophers of science of the 20th century, Karl Popper, tells us that really the most important aspect of the scientific method is staying vulnerable to falsification. So in this case, you know, we want to create a tool that's useful for all of you. We want it to be increasingly useful. And so a forum in which we can be openly self-critical is extremely important.
And extremely useful.
And it is, as we said, the essence of the scientific method.
That too.
Thanks, guys.
Okay. So we're going to talk about fractures here. And just a little bit about how to assess a possible fracture. And you look at, and these are the things you're going to look at when you're assessing the person that has the injury, and you're going to need answers to the questions that the program is going to tell you. So you want to assess the pain. I don't think there are questions about mobility, but you want to assess the mobility, because if a fracture is around a joint, the mobility is going to be decreased. You want to look for the normal other things: redness, swelling, and deformation of the sleek lines of the body contour.
So Marianne, could you say a little bit, give me an example. So for example, let's say I fell on my arm, injuring the forearm. What would you do to...
Did you fall with your wrist out, with your hand out to catch yourself?
How did you know?
Because I know Colles fractures when I see them.
So how would you assess for mobility in that context? What would you do, Marianne?
Well, you know, in that case, I would look for deformation, because a Colles fracture has a very particular look to it. There's sort of, your arm is straight down to the wrist, and just south of where your wrist, where the hand flexes up into the forearm, there's a little mound where the bone has sort of crumpled, so it's a little half-domey kind of deformation in the arm. Because a Colles fracture is generally not at the joint, it's above the joint.
Correct.
And so I'm probably not going to like mess with their arm, mess with their hand and wrist at that point, because I can already see from the deformation of the radius and the ulna that probably there is a fracture there. And the last part of this is short of observing a bone sticking through the skin, X-ray is the only way to be sure there's a fracture, because sometimes you can have almost immediate swelling that does actually deform the site, but you don't necessarily have a broken bone.
Okay. So, Marianne, well, I guess what I was trying to get at was, of course, there's no doubt. I mean, if you see a deformity in the line of the bone and it just doesn't look right, like a sharp angulation, there's a fracture.
Yes, more than likely.
But if you're not sure and you've observed a traumatic incident, so I'm just wondering, for the sake of listeners who may have not the opportunity to have physically examined all this. For example, if I were to be suspicious of a fracture of the forearm, the ulna, or the radius, I would probably use the mobility test if there were no visible deformation. Even if there was swelling and redness, it could be a contusion, it could be a sprain. But if on minimal rotation, by twisting the wrist a little, and the ulna and the radius spinning around, there was dramatic and sudden pain, we know we're causing nerve irritation, and probably it raises the index of suspicion that there is a fracture.
Oh yes. Oh yes, that is certainly true. What we don't want to do is cause any further damage.
Oh, so you wouldn't ask them to dance?
I wouldn't ask them to dance, no. But what I would ask them to do first is wiggle their fingers. So you want to test the most distal place first.
Good for you. And what would you do if it were the lower limb? Let's say something above the knee and you were suspicious.
Above the knee? It's full of giant muscles. And I wouldn't even bother with mobility there. I would just get it supported as much as possible, like I'm saying, splint it, and get them off to some place where they could have an X-ray.
What about below the knee? tib, fib.
Same thing. I mean, I'd ask them to wiggle their toes, certainly, but I wouldn't. See, it depends on where it is. Mobility is really about joints, and if this thing is not at the ankle, like you, for instance, skiing accidents where you get spiral fractures of the tibia, you can see if the person can move their ankle, but you've got to be very careful or they'll kick you, hopefully without the ski boot on. But in the mid bone, mobility is not the key issue. It's deformity at that point.
All right.
Because there's nothing really to move.
So I think we've developed a couple of good bylaws. One is first look for deformity. If deformity isn't obvious and you're still suspicious, move the most distal part in the least offensive way.
Yes.
If you get something that is exaggerated in the way of response, your suspicion, index of suspicion dramatically rises. They need medical attention and an X-ray.
Yes. Anytime I even hallucinate a fracture, they need an X-ray. That doesn't mean they don't need a homeopathic beforehand for pain control and such, but they definitely need a diagnosis. And the only way to do that, like I said, short of observing the bone sticking through the skin, is an X-ray. Because there are very serious sprains that are actually not breaks, although they can be ligament tears. But the only way to really diagnose those is an X-ray.
True. However, if you're wanting to give a first aid remedy, if you have a high index of suspicion, it's a fracture, even despite the absence of clear deformity. If wiggling something distal really creates a lot of pain, that will affect your remedy.
It will affect the remedy, and these questions or these points are all observations that you will make that will translate into the questions that are asked in the program.
Excellent.
Okay? Moving on. So go ahead, Joe. This is your first case.
Okay. So Lorraine was 30 years old when the fall occurred. She was in good health. It was a lovely Sunday afternoon, just like this one passed, and she was playing in left field in her usual softball league game. The count was 2-0. She got a solid hit, but while running to first base, she was momentarily distracted by someone in the crowd. Suddenly, she was down. Her right forearm bore the brunt of the fall. One look at the contours of the bone about midway up the forearm said it was broken. So that, Marianne, was one of your original observations. Bystanders rushed to her. She seemed not to be fully present. Her face was pale, her breathing rapid. When asked as to her condition, she denied anything was wrong. She just sort of shrugged it off, despite the obvious. This is an important observational point, guys. Do not discount what is obvious to you, especially if the patient does. That creates a red flag. Her not being present post-injury also is a very important red flag. One person present with first aid training approached, and as he came close to the injured part, she shrieked at him not to touch it. She was given remedy 1, and of course, as Marianne said before, an ambulance was called.
Okay, so what are the things, the symptomatology that you can see in this case that you think might be important?
Right, so we're waiting for you folks out there to respond.
All right. Celeste pointing out that she does not want to be touched.
Perfect.
Iman is suggesting perhaps potential shock.
Yes, definitely.
Denying the problem. Desire not to be touched.
Okay. All of those are good. And the nature of the injury is what? What kind of an injury is it?
Visibly broken.
We can't say fracture yet. We can't say fracture.
Sudden
But
fall.
what? Yeah. So a contusion. This is essentially a contusion. Something didn't hit her, but she hit something with some blunt object, that would be the earth, with force.
Then the pale face and the rapid breathing.
Yep.
And not being fully present.
Yes.
I think that just about wraps it up.
Yeah.
Okay. Well, we're going to part B there. Do you want to repertorize this part first, Joe, or do you want to just go on to part B?
No, I think we should do this while it's all fresh in people's minds.
Okay, perfect. Let me escape and so we get into Homeopathic HouseCall and we go to complaints. And where are we going to go? Now, we have bone fractures here. We also have traumatic injuries. What do you think would be most appropriate?
Traumatic injury from Celeste. Traumatic injuries, Darcy, Iman.
All right, let's go to traumatic injuries.
Yeah, we don't know if it's a fracture, even though we see we have
suspect it is.
Yeah, but we've got 3 sections here that we need to quickly DD: bone fracture, strains and sprains, and traumatic injuries.
Yeah.
The only one we know for sure is trauma.
Yeah. So this is another one of these conditions that has a caveat with it. And it talks about, if you don't know, people need to seek medical intervention as soon as possible. And you can administer a remedy, but you need to make sure that this gets a diagnosis. So, I think we can go traumatic. It's a traumatic impact, but it's not from the outside. But that doesn't really matter.
Yeah, no, it doesn't. It's traumatic.
The earth attacked her.
Exactly.
It was gravity's fault.
Which of the following, if any, describe the nature of the pain? Well, we don't know.
That's right.
Does the person experience numbness or tingling? I don't think it was stated.
No, it isn't. So we could hit this at some point at this one also have none of the above, or we don't know, or whatever. And this would be no.
Is the person still frightened from the ordeal? We have no direct evidence.
Yes, the person refuses to be examined.
Yeah, they didn't want anybody approaching.
We don't know what makes it worse.
Touch makes it worse. Oh, no, it doesn't.
Oh.
Sorry, she's averse to touch.
Yeah. We don't know what makes it better. Because it's really, in really acute conditions, you don't have this information.
Well, we haven't given arnica.
That's right. But you will see that we will be giving arnica.
We sure will. Let's
and what
read
do you think? Okay. Okay, so impacts, and she impacted the earth, and it probably caused bruising, and probably is going to have bleeding in the tissues and be discolored.
Well, yeah, it's the last sentence that really nails arnica.
Yeah. They may deny being injured at all and refuse to see a doctor or even refuse to be examined. That's one of the big arnica things.
And
so,
just before that, there's the fear of being people needing may refuse help for fear of being approached and hurt further.
Yeah. So probably everybody in the group got arnica because we all carry arnica with us in case the untoward incident should happen in our presence.
There were many arnicas in the comments.
Excellent. That's what I want to see, some degree of uniformity.
Okay, let's pop this down here and go to from current slide and the next slide. Okay, part B, Joe.
Now, after having been at the emergency room, the fracture being set, Lorraine was more present and aware. The threat seemed less. Having the cast on the injured part tightly supported just felt so good. However, once the initial dose of painkiller wore off, it was observed that the slightest jar to the area set off a sharp pain despite the cast. Lorraine protected the cast from further commotion with the added support of her other arm. So she used her healthy arm to grab hold of that injured arm and hold it steady. She was given remedy too. So the question now is, what are the available symptoms to be respected in Part B?
All right. Worse from the slightest jar.
Excellent.
Worse from movement.
Sure, that's acceptable.
Or perhaps better from splinting.
Yes, definitely that.
Is certain. That is certain.
Okay. Let's see. A sharp pain.
Yeah.
Supporting or splinting. Let's see. Someone suggests better wrapping.
I think it's the wrapping is causing support, which I think is a thing. It's not like covering or uncovering. It's about support.
And there's a partial one here, better pressure.
Yeah, and once again, I think it's about support. The support in this case happens to be pressure.
Or pressure.
Because it immobilizes.
Yes.
Pressure to a particular part.
Yeah.
That is to say.
Pressure to the injured part.
Exactly.
Yeah. Okay, shall we repertorize Part B?
Yes, let's toddle off to Homeopathic HouseCall.
And this time, we can actually say fracture. And once again, the wonderful caveat. Okay. So it looks like this is a simple fracture. It's obviously not a compound fracture. It's not a crushing injury, and it has nothing to do with their eye socket, unless people don't understand their anatomy. And so the bone was set, and they didn't complain of itching. And they had shooting pain.
It's interesting. Should we say shooting or sharp?
Oh, where's sharp? Oh, yeah, she did say sharp. I'm sorry, not shooting. Not hypericum-like. Okay. I
Well,
think they probably would.
well, they've seen one.
Yeah, so we'll say yes.
No, it doesn't resist.
Nope,
In this case, we're irresistible.
exactly. And they don't talk about spacey or circulatory shock or any of that stuff, so we can say no. Splinting or immobilizing, definitely.
Yeah, that sort of captures it, doesn't it?
Yeah. Yes, it is worse when the person moves. And we can only say injured part here because it's that jarring thing. And, well, I would go with this one. What do you think, Joe?
It's debatable, but let's go with that one because the jar could essentially be from moving a different part of the body, and yet the jar could be transmitted.
Yeah. Well, actually, this doesn't say jar. This says moving any part of the body, and that wasn't really it. It was more like moving the injured part with the jar.
Yeah, you're right. No, this is not a past thing.
Well, symphytum is up there first.
Let's take a look at it.
So I think the first sentence is good. All fractures can benefit from symphytum in the long run, but not immediately after the injury.
So where are the symptoms that might indicate symphytum?
Okay.
There it is.
Deep bone pain, which they didn't complain of.
No.
Bone aches, not necessarily. No itching or prickling. And this is old fractures, which this is not.
Yeah, there's very little similitude here.
Right. Let's look at bryonia. So bryonia, pain on motion. And it says even motion in other parts of the body, and we really weren't given that information. What they didn't like to be was jarred. So they didn't like the area of the injury moving at all, that's for sure.
Yeah.
And so the pain, yeah.
Oh, I'm sorry, Marianne, you go ahead.
No, go ahead.
No, please.
I was moving on. You're still on that point, so go ahead.
No, I was moving on too. I was looking for the bracing part. That's coming ahead, and that's where you're going, so go for it.
Yeah. So the pain improves with splinting. And that's one of the things about bryonia. They like to have that injured part splinted some way, whether it's lying on the injured side or having the injured side supported.
Exactly. You know, as a chiropractor, Marianne, I see a lot of motor vehicle accident victims, and when somebody comes in with a whiplash, even though they've just arrived, often I'll see somebody walk into the office, two hands powerfully compressing either side of the neck so that they don't have to move or be subjected to jar. Just seeing that person do that to some part of their body as they walk into the office alerts me to the possibility that they're going to need bryonia.
Yeah, I totally agree. So I think bryonia is our remedy at this point.
It seems so.
Okay, let's go back here at home. Dashboard, PowerPoint, current slide. All right, part C.
So later that week, the sensitivity died down nicely after the bryonia. And with the exception of the cast, life went on as usual for Lorraine. No drugs were needed. Towards the end of the week, an annoying ache began. What's more, just at the site of injury, she reported a rather sharp prickling. She was given remedy 3.
All right.
So first, what are the available symptoms, guys?
Oh, yeah. Go ahead. I'm just getting my thing up.
Excuse me. The sharp pricking feeling.
Yes.
That's the only thing we have in so far.
Wasn't there an aching in there too?
There was.
And it was, it was post-acute injury, so it had been going on a while.
Mm-hmm.
Pain is at the site of the fracture.
Right.
That's all we've got right now.
Well, and that's pretty much that part of the case. Joe, would you agree?
Totally. This now is a case with really only 2 symptoms: the prickling at the site of injury and the deep bone ache.
And the fact that it's not new.
Correct.
So, simple fracture. Yes. So, no itching at the site.
No, it's prickling. It's similar.
Let's see what we got.
We've got a deep ache. Excuse me.
Bless you. So, not spacey.
I think we're beyond the splinting.
Yeah. But it was better splinting, so I think we can still put a yes. Well, we can still put a yes in there. Because she still has the cast on. And motion at this point doesn't make the pain worse.
No.
And still pain at the site. And we come out with Symphytum. And Symphytum is our guy.
Well, let's read it. What in the reading of the actual Materia Medica might convince you, Marianne?
Well, it's a fracture that's been there for a while.
Okay.
And it actually is healing. But now there's some deep bone pain. And as they say in here, you consider eupatorium, but it's not expressed, at least in the case, as seriously as it would be if it were a eupatorium case. But there are aches and prickling. They didn't ask about prickling, but it says prickling here. And this is not an old fracture, but it's a fracture that's healing. And we don't know about failure to heal. So I think Symphytum is our guy.
Symphytum has the highest level of similitude. And you know, that itching or prickling at the actual site of injury, it shows the body's actually trying to heal that injury.
That's what I would think. Yeah.
And Symphytum is such a miracle when it comes to slow union of bone fractures. What a wonderful remedy.
It is. It's an invasive, beautiful plant, too.
Very invasive. Almost impossible to get rid of, I'm told.
I know. You better like where you put it, because it's going to be everywhere in the bed. And do you want to say a few words about how wise it is to use Symphytum before the bone is actually set?
Well, we don't want to do that. We don't want to provoke a strong healing response while the bone is malpositioned.
Exactly. So you never use Symphytum before the bone has been assessed and splinted, ever, because it can cause a giant problem.
Reminds me of calendula and puncture wounds.
Yeah. Oh, yeah, and then the abscess forms.
So, in case there is an infected area in a puncture wound, you don't want to stimulate wound healing and granulation tissue to seal an infection in.
It's why we don't suture dog bites.
Yeah.
Or people bites. Or cat bites.
People bites are actually more septic. Yeah, they're the most septic.
They're worse than cat bites, and cat bites are bad.
Yes, they are. Well, all bites are bad.
Well, I know, but some mouths are more filthy than others.
Yeah, well, you don't want to be biting anybody if you're a WWF wrestler or anything like that.
You could lose an ear. Or if you go to soccer games.
Exactly. But Marianne, with this particular case, what I was hoping to demonstrate, because it had a part A, a part B, and a part C, it was the same case. It was all Lorraine, I believe. But just to see that conditions change as they heal. And there are remedies for each phase.
Yes.
And again, to re-emphasize our motto that I think you began the webinar tonight with, what we're after, especially in homeopathy, is the purest of observation. What is it we see? That's it. You take those particular symptoms to the materia medica, and it often gives you a very satisfactory answer.
Right. And also that healing is really dynamic. And so what you need in the beginning changes dramatically as the process of healing continues. And so in acute cases, you can end up giving 3 remedies in the course of a week or a week and a half. Because as the person heals.
Absolutely. You should not be shy. Marianne, can you explain, what do you mean there by dynamic?
Well, it moves from one phase to another. It changes.
So it's
and
moving.
Hopefully it changes for the better.
Yes. Because if it's a negative dynamic, it's called disease.
That's right. Well, it's called call my lawyer. But but this is a normal progression. And the point is that you can nudge that progression along on a positive way by giving the proper remedy at the proper time.
The other thing I want to point out, for example, in Part C, all we really had for this symphytum prescription were 2 symptoms, the deep ache and the prickling at the site of injury. You don't need a page full of symptomatology. 1 to 3 or 4, more than enough.
Yeah. Which is why your observations are so important.
Exactly.
Good. Are there any questions about this case in 3 parts?
Not about this case in particular, but when we got started on fractures, there was a question.
Okay.
Is there any, so, we talked about how to recognize a fracture. Would you give any hints for perhaps recognizing a fracture in animals?
Same thing, actually. You look for deformation first, and you see if, first of all, critters, I find, always need arnica first, because they're very blasé about their injuries in general. If they're not, you give them aconite. But usually, they're going to limp. They're going to not use the limb if it's a limb, which it usually is, and you're going to know right away which part you need to examine. So animals in a lot of ways are easier than humans.
Yeah,
When
I would say, yeah, I would agree. Deformity,
you know,
lameness, and sensitivity to touch.
yeah. I mean, you always, because you never know whether they fell and hurt it or they stepped on something. When I'm examining critters, I always start at the distal end of the critter on the bad leg, and I look at everything between their paws, and I, flex their little toes, and then I start up very gently, feeling the contours of the bones. And when I get to the ankle bone, which is not the same as ankles in people, um, I check that very gingerly and work my way up into the shoulder. Because sometimes it's way up in the shoulder. If they fall and pull ligament or do a sprain or a strain, if they jump off of something, a lot of times it's not in the leg, it's in the shoulder.
Yeah, good for you for emphasizing working from the distal end of the limb.
Yeah.
And also watching yourself for getting bitten.
I've never been bitten by a critter that I've examined.
Interesting.
I haven't. I don't know why, but I just haven't. Which is why I'm sort of stupidly fearless about doing it.
Must be the saint-like quality around you, the aura.
Oh, yeah, it's that extra light. Any other questions about fractures?
Yeah, so how is it, someone was just wondering about the wording here in Part C, annoying aching, and we reported that as a deep ache. And is that simply because we know that this is a fracture and that that's where the pain is?
Yeah, probably because it's a bone.
Yeah. And then the other question that came in, hang on just a sec. Someone's wondering about the about symphytum, and how careful do you have to be before you start giving it? Do you need to have another X-ray after the setting in order to start giving symphytum?
I don't think so.
I don't think so either. Usually after the first couple of days where pain control has been established and the bone's been set, I always give symphytum as a matter of course, even if they're not complaining of what I would think of symphytum symptoms, because it stimulates bone growth, bone healing. It stimulates callus formation in bone. And they're usually, depending on what the fracture is, they're usually going to have another X-ray 14 to 18 days after it's set. And at that point, my experience has been the doc saying, I can't understand why this bone is healing so well. And I don't give it every day. I'll give it like after day 4, for instance, and pain control has been established, I'll give symphytum 30C every other day for a week.
Yeah, I would tend to agree. That's a point I wanted to bring out as well. Symphytum every other day for a week is just fine, but I would not prolong it. You don't want to dull the body's response to the remedy by overuse.
Exactly.
All right. That covers all the potency questions we got.
Okay.
That's all of
Moving on.
Yeah, that's all of our fracture questions.
Okay.
Next case.
Well, and here are our symptoms, but we've already done that. Oh, it's our little egghead.
Yes.
Go ahead, Joe.
The broken egg. With the warm weather starting up soon, Jason wanted to get the family swimming pool ready for filling. He was cleaning the bottom of the pool when he slipped. He tried to break his fall with an outstretched arm, but it happened too fast. There was partial impact to his hand and arm, but the primary force was to the bony part of the forehead just around the left eye, so to the bony part of the forehead and the orbit. His wife rushed to help. As she approached, he immediately put his uninjured arm up to block her approach. The area was clearly bruised, swollen, and red. In addition, there was a significant abrasion above the eye that was bleeding, but not profusely. The area of the abrasion was a bit inflamed. Inflamed meaning red and swollen and tender.
Okay.
So what symptoms do we have, folks?
Sorry, my microphone was off. I'm sitting here talking to myself. We have a contusion.
Okay, Hart.
We have a contusion.
Indeed. We have bleeding, bruising, swelling, and redness. We have an aversion to being approached.
You bet.
Let's see. Blunt force trauma to soft tissue. The important location there around the orbit of the eye. That's what we've got so far.
I think that pretty much covers it. Marianne, did we leave anything out?
Oops, how'd that bee sting get in there? I don't think so. Everybody don't look at this. Okay, so I had these things.
Okay. So if we take a look at this present slide. Whoops.
It's all right. I'm just going to do this right because I screwed up. I thought I'd gotten all this straightened out perfectly, but I was incorrect. Okay. There we go. Current slide. All right.
Okay. So we have a sudden injury to the forehead, a contusion, blunt trauma to the area around the eye. We have to be concerned for possible fracture. We have a fear of approach. We have abrasion to the area of impact. So there's an overview involved here. So here we have, before we had one injury that translated itself over the course of a week into 3 presenting remedies. Here we have one injury all occurring at the same time. It has sort of a primary and a secondary. 2 possible problems. The first, blunt trauma to the bone. The second, abrasion to the skin. And because we have 2 possible problems, there are potentially 2 remedies, but the priority will be the trauma. As well, Jason needs to be properly medically evaluated for concussion and fracture, but being given a full neurological as well. Marianne, any comment on that?
Were most of you guys here for the head injury thing that we talked about last time? And if so, what's the consideration?
One person is saying concussion.
Concussion, definitely. And what else? 48 to 72 hours down the line.
Someone suggesting dizziness or altered consciousness.
Well, those could be symptoms of the problem, but what would the problem possibly be?
Bleeding on the brain.
That's right. Intracranial bleeding between the meninges. So that's something that you also have to have in the back of your mind when you're looking at a case like this. Which means that you need to observe the patient for more than just this moment of the injury. Anything else, Joe?
No, I think that says, well, we should go to Homeopathic HouseCall and see what we can do with this, having first divided it into two issues. One, the blunt trauma. Second, the abrasion. So first, let's go for the blunt trauma.
Okay. So traumatic injuries?
Well, we don't know if it's a fracture, and it's certainly not a strain.
Well, the thing is that what we have is traumatic injuries. So what other thing?
Well, no, traumatic injuries is it.
So once again, he didn't talk about pain?
No, we don't know.
We don't know about numbness and tingling. We don't know about muscle weakness. And he's not particular. Do we know if he's frightened, Joe? He's just denying that he wants help.
Right. He's just denying any approach.
Refuses to be examined.
You bet.
There it is. And we don't know what makes it worse.
Yeah, we don't know. And you know, Marianne, just to stop for a second,
okay.
Isn't that the hardest thing in science to admit?
That you don't know.
To know when
and
you
it's
don't
frustrating.
know. It's so frustrating. Socrates said the height of wisdom is to know that you know nothing. Anyway, keep going.
And we love Socrates, although he met a bad end with Cone Maculatum.
Yes, he has to get a new bartender. Well, we don't know if he took arnica.
We don't know because he hasn't taken that yet. But here we go. And so what do you think?
I think this is a pretty clear case of arnica.
Yeah, I don't think anybody would try to argue us out of giving this guy a little arnica montana.
Yeah. So
anybody disagree?
Oh, let's wait for that.
Are we getting any disagreement, Hart?
I don't think we will, Marianne.
I don't either.
So why don't we move on to the let's do the abrasion.
Oh, okay. Dashboard.
Complaints.
Where's abrasion?
Let's go down a little.
So there are a few people wondering why we didn't use head injury there.
Oh.
We could use head injury.
Let's try it.
Okay.
This is a great risk, but let's try it.
No, I think we're okay.
I think you're even more likely to get the same remedy using head injury.
We don't have convulsions, seizures, any of this stuff, none of the above. So he's not experiencing any temperature stuff. No. No. They don't say he didn't say he hadn't been injured. He just said, "Don't touch me."
Right. There it is. Fear of being approached. So yes. I don't know.
We don't know. Yeah.
And just to clarify, some of the things that we don't know from a written case are things that we can very easily examine in a face-to-face case.
Exactly, because that's what it's all about, that observation.
And you know, one of the beauties, Hart, as just as you mentioned, one of the beauties of this system is that if you are examining somebody, these questions can be used in the course of that examination
That's right.
to help sharpen what's going on.
You can reverse engineer this thing. It's perfect.
I bet it is.
Okay, well, arnica comes up number 1 again, and actually it comes up as the only thing because it's the right thing.
It is the right thing. Now, back to the abrasion.
Back to the abrasion. Oh, shoot. We didn't even figure out where to find the abrasion.
It's under wounds to the skin, I think, Marianne.
Okay.
If you go back to the dashboard under wounds, you'll see it, I think.
You know, this is really helping us to
Learn to navigate.
Deal with this program. Well, learn to navigate, but also it gives us ideas about what we need to do, too. Wounds T. All right, wounds to the skin. So this is an abrasion. So it's not a laceration, it's not a puncture, it's not a nerve, it's not a crushing wound, it's an abrasion. So it isn't any of those. Very recently. Surgical procedure. No. So it was red and swollen, right?
Yep.
We don't know about the pain.
Nope.
We don't know what makes it worse.
Nope.
Because nobody asked him.
Yeah. What a bad case taker.
Yeah, and actually, would you consider any of these, Joe?
No, I wouldn't.
Me either. Because I think in this case, that abrasion is something that really isn't going to have to be dealt with unless it suppurates. And if you do good wound care, it is not going to get infected.
I would agree.
So this is one time where this would lead you astray. And besides, you were absolutely right. You know, where is the gravity of the case? And that is so important when you've got a bunch of things going on. You got to ask, where is the gravity of the case? What's the most important thing to treat first? And go ahead.
Yeah, I was just going to follow on the heels of what you said, Marianne, saying, what is the most important thing? And once that is treated, wait and see what happens next. Nobody's bleeding out here. Nobody's in an awful lot of pain.
No.
My guess would be that by the time you were finished with the arnica, even the abrasion would have probably healed itself quite a bit.
Well, particularly if you've been cleaning it every day, keeping it dry, and putting something like calendula cream on it.
Yeah.
A caveat, do not put ointments on abrasions. I mean, everybody loves Neosporin, but ointments are not good on abrasions because they only take care of the bugs that they are composed to take care of. And any other bugs that are in there, that ointment, that petroleum product, seals them under the wound, and then the wound is more likely to get more inflamed if you use an ointment on an abrasion. So now, don't do it unless it's a horse. And the reason you do it in horses is because flies can't land on petroleum products. And so you have a better chance of them getting well if they don't have flies running around on their wounds. But humans don't necessarily have that problem.
Now, Marianne, if I normally do want to treat the abrasion, you're right, I will not use a calendula ointment, but what I will do is use either a calendula succus or a tincture. I'll turn the tincture
Oh,
into a lotion,
yeah,
and I'll put 5 to 10 drops per half cup of water and just soak some gauze in that, create a dressing, and put that on for a few hours, changing it every few hours.
yeah. I just like the calendula cream. It seems to be well absorbed and it does what it's supposed to do. The problem with tincture, if you don't dilute it very well, you will not be getting flowers from the person you stick that thing on.
No, it will sting quite dramatically.
Yes, it will.
Good. Next case.
Okay. First, any questions about this case or about the treatment of this kind of contusion and abrasions in general?
Let me check. Okay. Let's see what we have. Yes, we had a question about how to tell if a patient has some shock.
Probably the first thing you'll notice is their mentation changes.
Yeah, they're out of it.
Yeah, they're disoriented. That's the most thing. And if you have a blood pressure cuff, see, we're talking to people here that don't necessarily have equipment. So if you see a change in mentation, the way they answer questions, if you see a dilation of the pupils, if you see some level of uncoordination, those are all indications that a person is heading towards that. They also can start to feel cold. Not everybody complains of feeling cold, but they can, because what's happening with shock is that your blood pressure is dropping. And when your blood pressure is dropping, usually the blood vessels constrict to protect your core, and so your extremities are freed of the normal blood supply they would have, and so they get cold. And patients complain of being cold when they start to go into shock.
Exactly. So, Marianne, I think for myself, the first thing is I would suspect shock if they were in a moderate to a severe trauma. And then,
Yeah.
if I were at the scene, there's a possibility that I know the person, and when you see the person, they just don't look themselves.
No, they don't make eye contact.
And they don't look like they're recovering. They're kind of out of it. They're a bit on the slow side, and yet they usually want to be covered. When you see, and the weakness, and when you see all of that, you get concerned.
Right. And shock is one of those terms that gets tossed around very lightly. And what we're talking about here is the kind of circulatory problem, as opposed to psychogenic shock, where a person has a fright and passes out. It's a vagovasal reaction. And that's very different than a metabolic shock, where you actually have a decrease in blood pressure that affects the entire system.
And if you wonder about that, when you're working in Homeopathic HouseCall, you can visit the condition circulatory shock.
Yes.
And see a nice description at the top. Rushing of blood to the center of the body, often caused by traumatic injury, resulting in pale skin, bluish nails, weak pulse, racing pulse, rapid breathing, chilliness, thirst, and possible loss of consciousness.
Yes.
Well done, Hart.
All possibilities.
Just reading it off the screen.
Possibilities. Okay. Are we good with questions there?
Let's get back there. Yes.
Okay. All right. Go ahead.
It was a Sunday of a family barbecue. A good time being had by all, and the weather was cooperating beautifully. A scream broke the hum of the conversation. Little 5-year-old Sarah had been stung by a bee just above the right eye. The area immediately began to swell and turn red. The swelling seemed striking for its degree and intensity. Sarah complained that it burned like fire and welcomed her mother's offer of a cold compress. In fact, once it warmed up a bit, she demanded a cooler compress immediately to relieve the pain. But folks, what have we got here in the way of symptomatology? What is it we can take to the bank, take to the Materia Medica to see?
We got a bee sting. We have better from cold and a swelling, burning like fire. Swelling, redness, burning.
Sounds good.
Sounds good.
And look at that. So, let's go up here. So what are we going to look at here?
I think we need to go back down to where we were before, do we not, Marianne? Back down to wounds of the skin.
Insect bite or sting. Very recently. None of the above. Inflammation, yes, generally red, swollen, and hot.
Sure is.
And burning or stinging? She said burning. We don't think so. Make the pain worse? We don't know, because that was not stated.
We could say that heat or hot applications make the pain worse.
I actually wouldn't say that unless it was stated.
Well, when it warmed up, the pain was worse and she wanted more cold, something colder.
Right, but it got less cool. They didn't apply heat. It's just that the cold got less cool because her skin was heating it up.
Fair enough. You see how homeopaths argue, guys? Go ahead.
Definitely yes. And here comes our little bee. So this is a pretty classic. This is a pretty lovely classic Apis case.
What convinces you that it is so? Like, what exactly convinces you, Marianne? Not everybody might know the Materia Medica of Apis.
Hot, red, swollen, better cold applications, insect bite, but the hot, red, swollen, better cold applications in this case really sort of led me down that little garden path.
Yeah. To me, I also want to see the being struck by the level of swelling.
Yes. Well, there's the swollen part.
So the swelling and a burning or stinging pain, better from cold.
Yes.
Now, why would it not be ledum? Ledum is better from cold.
Yeah, but ledum doesn't have all that sudden swelling. And actually, the swelling of ledum is, and this case really didn't say this, but the swelling of ledum is more dense.
Okay. But yeah, the ledum does not have the dramatic, disproportionate swelling and redness. In fact, the area would be more staid and purple.
Yeah, exactly. The color change is different.
Excellent.
Any questions about this case?
No. No questions here, except someone asking if all bee stings show symptoms like this.
No.
No, they don't. Actually, I've had stings of various critters, actually more wasps than bees, that have actually been ledum.
With what predominant leading symptoms, Marianne? This is what we do to each other, folks. We want to find out what we know, and then we quiz each other to model the other person. Go ahead, Marianne.
Well, usually the sting forms a hard knot, a T-cell reaction, if you will, instead of that sort of spongy, red, real swollen, puffy kind of thing. It gets to be a hard swelling, maybe with a little almost white at the center, and it can have red around it. And this is one of the, it looks like the bite of a tick where you have target lesions.
Mm-hmm.
You can have bee stings that look like that if that's how you deal with them. And then it's not an Apis case.
No, without the swelling and the redness, it's not an Apis case.
Well, they're swollen, but in a different way. And they're red, but very circumscribed. You know, it's not just sort of through the tissue like you see with Apis.
And you need that amelioration from cold.
And it's still amelioration from cold.
Yeah. Yeah.
Any other questions? So we're going to talk about lacerations now. And when you assess a laceration, you want to check, first of all, for the type of bleeding. And this is really, really important. Is the blood just flowing, sort of oozing out, or is it pulsing? If it's pulsing, do not stop. Put a compression dressing on it and get them to a someplace, because that means an arterial bleed. Most lacerations are venous bleeds, and venous bleeds have flowing blood. I mean, it can be flowing really fast, but it's not spurting like Old Faithful. And you'll know an arterial bleed when you see it.
Yes, and that's trouble right away.
It's total trouble right away. And if the laceration is on the hand, you want to make sure the tendons are intact. So you ask them if they can wiggle their fingers. And you want to know if they have feeling in the digit, because they could have actually cut a nerve. On each digit in the hand, there are nerves running up each side of the fingers. So you test for that. Some of this is more what you do before you anesthetize them to sew them up. But it's something that you guys can check out too. And also you want to know if there's debris in the wound. If you can get the big chunks out before they go off to have it, whatever's going to be done to it, when you wrap it up, it has the potential to cause less damage. If you've got a bunch of junk in there, it can cause a problem. Do you have anything to add to that, Joe?
No, that's good.
Anybody else have any questions about assessment?
Nope.
Okay, go ahead.
So, Adrian was just trying to be a good husband, woke early to wash the dishes from the previous evening's meal. He was almost done when, in trying to place a glass of water in the dish rack, it slipped and broke. On picking the fragments out of the sink, he sliced open a finger. None of the fragments lodged in the wound. It was a clean, almost incision-like wound. The bleed was minimal, but it was red, swollen, and sharply painful. He could not tolerate the slightest touch. What have we got in the way of symptoms? We await your response.
So So we have a clean incision, exquisite pain, red and swollen, less bleeding than might be expected. Sharp.
Yeah, because hands bleed like crazy.
They really can.
Worse from the slightest touch.
Yes.
And there's nothing lodged in the wound that needs to be removed.
Thankfully.
Or that would be
Which we're all
stopping the
thankful.
bleeding.
Yes.
That's it.
Okay. So you got it all right? Escape.
Apis already?
No. Jeez Louise. Okay. We don't have laceration. What are we going to? Wounds?
Wounds of the skin.
To the skin. Laceration. Very recent.
Sure was. Now, the wound is not from a surgical procedure.
Right. None of the above. Yes, there's inflammation. Generally red and swollen, not necessarily hot. No pulsation.
Yeah.
Just the wound edges are red.
And I would say generally red, swollen, and hot.
Okay. Okay. Pain.
Pain is sharp.
No.
Touch.
What makes it touch? Right. We don't know about cold applications, do we?
No, we don't.
Okay. Shall we read staff?
I think so.
Go ahead.
So wounds that need staph can be rough cuts in the skin or surgical incisions, especially if the incision was stretched during surgery. The wound is sensitive to touch, and the pain is described as sharp. Those two phrases really call out to homeopathic similitude. There may be inflammation around the wound. The surgical wound may remain painful after surgery or not heal well. This is a very typical Staphylos agria case. Anything
Perfect.
you'd like to add, Marianne?
No. I agree.
All right, let's move on.
Hey, I hate to agree with you, Joe, but I do.
It has to happen sometimes, but we'll get over it.
We'll get over it. Any questions about this case?
Someone was wondering, what is a stitching pain?
The stitching pain is exactly as it says. Now imagine somebody stitching a piece of clothing. It's like a needle going through a couple of layers of material in one direction or out the other, but it's kind of like that. It's a sensation.
And pulling it tight.
It's a sensation as if something is going in or something is going out, yes, and it could have
And
pulling it tight.
compresses it. And pulling it tight. Yeah.
But it's that suddenness, that piercing penetration, the pulling tight, that kind of feeling.
I've heard it said that in Kent and previous repertories, stitching was basically the term used for a very sharp pain.
Yes, it is kind of garbage can rubric for sharp pains.
Okay, so more blunt force trauma.
Marianne, is this a threat?
No, I am
No.
so nonviolent.
Well, yes, that was my initial impulse.
So blunt force trauma usually causes problems with bleeding under the skin in some places. And so a bruise is just an accumulation of blood in the tissue, and it's due to trauma or sometimes a metabolic clotting problem, but that is not what we're talking about here. And it's not usually serious unless the cause is metabolic or non-traumatic. A hematoma is an accumulation of blood that is much larger. It's in the form of a clot, and it's between big big areas of tissue. And it's potentially dangerous depending on where it happens. And we've already talked about bleeding in the brain, bruising in the brain, and so we don't have to do that again. Compartment syndrome is one of the places where you have a serious hematoma. Compartment syndrome happens in the limbs where you get a hematoma between the muscle bundles, and if it gets large enough, it can compress nerves and blood vessels, and you can lose your leg or arm. And it usually happens in extremities, and mostly in females, it happens in the thigh muscles, sometimes in the calves. But in males that have larger muscles in their brachial, in their shoulders and arms, you can see compartment syndrome in the upper extremities. So here is the case. You've got a 27-year-old man that comes into your office complaining of pain in his arm that has lasted for a week. He's a carpenter, and last week some 2x4s fell on his arm. He says that the site aches and is quite painful to the touch. It's worse if he gets warm water on it, and it is better with cold compresses. The area is purple, but fading to yellow around the darker bruise. He did not come in when it happened because he didn't think it was serious. He has good range of motion in the arm and the hand, but complains of deep aching pain when you touch the area. So, what have we got symptom-wise?
No submissions yet.
Okay.
Must be getting late. People are slowing down.
I know. Well, I'm slowing down too. This may be the last one. It looks like it's 25 after.
Yeah, we have some things coming in. Painful to the touch, worse from warmth and better from cold. Let's see what else we have. Those are the big ones. Everybody's got the worse from warmth and better from cold. Okay. A suggestion of an older injury.
Mm-hmm. That's good.
Purple to yellow, purple bruise. I am sorry for the noise, folks. I hope that's not too noisy for you. We're having
Sounds like you have dinosaurs in your room.
Oh, geez, we have a massive thunderstorm going on, and
oh, cool.
The fire trucks are flying by, and anyway. I think that kind of covers us. The color.
Yeah, and he has a deep aching pain.
The trauma. The aching pain. The worse from warm and the better for cold. That summarizes what people have sent in so far.
I think that's reasonable.
So in this one, we could choose bruising, or we could choose traumatic injuries. And I'm just going to go with traumatic injuries right now. And then we'll do bruising and see if we come up with the same thing. So it was definitely a blow, and it was an outside blow. And it's bruised and sore. Don't know that. No muscle weakness. No fright from the ordeal.
Yeah.
Does a person refuse to be examined or claim that they are not hurt? Now, do not be fooled. What is the present situation for this person?
This is after the fact.
He came to your office now. So right here it's a no. His worst touch, and washing the injury with warm water or warm applications, and cold applications make him better. He didn't take any arnica, more fool he. Let's read Bellis perennis. So Bellis is involved in deep bruising. And I don't know if any of you have had 2x4s fall on some part of your anatomy, but it's not pretty. And it's not a surface wound. So this is a fairly deep bruise. And it's sore and not resolved after giving arnica. In this case, what did he need when the 2x4 struck? Given the symptoms from the case.
People are feeling arnica would have been a good choice right then.
Arnica would have been a darn good choice then. He may not have gone to Bellis perennis had he had the arnica then. But don't knee-jerk arnica for every case of bruising. When it goes on down the line and it sticks around a while, you need to think about Bellis.
Well, Marianne, wait a minute.
Yeah?
What would DD, this is difficult, what would DD here, Bellis from Leadham?
Well, he is worse warm application, better cold and worse warm, and of course Leadham is better cold. But there's no puncture wound involved. This is a contusion with deep bruising. And a contusion with deep bruising is a Bellis case.
So you're saying that attention shifts from Leadham because there is no puncture.
Yeah.
Okay.
And Bellis is not always about outside trauma. See, you can also use Bellis after surgery or delivery of a baby, because that's a traumatic event, particularly the baby part.
Yeah, it's especially indicated in injury through abdominal surgery.
Right. So this is something that you see, like, for instance, if you have an automobile accident and you hit the steering wheel of your car because you weren't wearing your seatbelt, idiot, it becomes a Bellis case very soon. And actually, even things like lower back pain that have been going on for a while, let's say you've had an injury of some sort to the lower back, and you took arnica to begin with, and arnica did really pretty well to start out, and then you have lingering pain that's just deep and aching. You can try Bellis, and Bellis usually works.
Excellent. Good to know.
Any questions about this case?
Not about this particular case, but we do have a question that might be a good place to wrap up since we're out of time.
Yes.
And we have a question that came in a while back about bleeding on the brain and would you make a remedy suggestion? I think we're, we've got a lot of homeopaths here, experienced homeopaths, and there have been a lot of dose and potency questions that I've kind of been putting off. And anyway, there's someone here who would like to know what you do recommend if you find out that there's bleeding on the brain, 48 hours later. Is there a remedy you recommend in that situation? Obviously, you're going to get the person to the hospital, but is there a remedy?
Yeah, they're going to the hospital. Actually, I start by redosing arnica.
Arnica would be most frequent, but in each case the answer is always the same. In homeopathy, we take the case.
Yeah.
So based on the original thing of head injury and trauma, in the absence of symptoms which further differentiate a different remedy or contraindicate arnica, then the go-to is, just as Marianne said, is arnica. But should there be other things, memory loss, change in mood, change in sight, headache with certain modalities, change in the thermal modalities, you would go to the remedy indicated by the global pattern.
Yeah. The one subarachnoid hemorrhage case that I've treated, I ended up treating it with arnica because the only thing was this leak, this little bleed, and the patient otherwise was not having any other symptoms. It's just they'd get the CAT scan and there'd be that little bleed there. And it took about 3 doses of arnica to stop the bleed. I mean, maybe the bleed stopped by itself. You know, who knows? But it had been going on for 3 weeks before she called me.
Yeah, I agree. There's arnica by far is the most frequently used.
Yeah.
All right. And I do want to explain to people that part of the reason that we're not doing a lot of dose and potency discussion tonight, if at all, is that that particular topic tends to vary widely from practitioner to practitioner. Certainly, I think that Joe and Marianne have different potency styles, and there are a lot of other speakers who we have on who have very different dose and potency styles. The right remedy always seems to work regardless. Am I right about that?
Yep.
Pretty much. Pretty much. You know, and we all have our styles for a reason. And
it's the way we were taught, right?
well, actually, it was not. I don't do it the way I was taught.
No.
Because I'm more in the medical model than most homeopaths. You know, I want control. Particularly in acute cases, I want control. So 30C is the potency I choose. Lower than that, I don't get the results. I haven't gotten the results I wanted. So 30C I feel safe in giving frequently as needed. And I see results. Any higher than that, I wouldn't want to repeat a higher potency, and I don't want to give a lower potency if I need to give it again. Yeah. So that's just what I've come to.
So in Homeopathic HouseCall, because we were going to have non-homeopaths using this website a lot, we already have a lot of non-homeopaths using this website. When you get to a differential, you know, in this homeopathic talk, we have stopped each time that we get to a differential. When we're seeing arnica and Staph aureus and apis, we take a look at our differential and we choose. Now, if you were using the site as someone who maybe didn't know immediately what they wanted to do potency-wise, you can select the remedy, and then you get the recommendation for the potency.
Right.
The way we have given recommendations for potency in Homeopathic HouseCall is simply this. Give a 30C pellet. There's no reason to give more than 1 pellet at a time. Just give a 30C pellet. And then we have very specific instructions for repeating. You know, depending on the condition itself, how frequently do you repeat? Those are very specific in there. So those are all in there in Homeopathic HouseCall. There was one other point. For those of you who really want more discussion about dosage and potency, and there are apparently a lot of you, I would highly recommend Will Taylor's course by that name. Actually, I think it may be Potency and Dose, but it may be the other way around. But at whncourses.com, there is a full, pretty sure a 12 or more hour course that Will taught for us a couple of years ago on dose and potency. And that should give you lots of things to think about that way. Joe and Marianne, anything else? We've covered our questions.
I don't think so.
I don't think so. I think I've had lots of fun tonight. Thank you both.
Yeah,
it was very fun. Thank everybody.
And thanks to all the attendees.
You bet. Yes.
Spend your evening with us.
Yes, and there is one more session in our series, and that is Kim's session that got put off because he was unwell. And I'm going to check real quick before we go, check the date.
August 12th, I think.
For you. August 2nd.
August 2nd.
At this same time. So Tuesday, August 2nd, 5 p.m. Pacific, 8 p.m. Eastern. We'll be back with Kim for the last in this series. Thanks, everybody.
Hart, thank you so much for moderating this evening.
Thank you.
Yes,
enjoyed
Hart,
it, guys.
Wonderful job as usual.
Thank you. Take care.
Bye-bye.
Good night, all.
Bye.
Okay, Joe.